Hello and welcome to At the Heart of Health with Dr. James Marcum. In today's well-marketed world, it's hard to know who or even what to believe when it comes to health care. In each program, Dr. Marcum, a board-certified behavioral cardiologist, takes a balanced approach using common sense modern medicine and the ultimate source of truth, the Bible, recognizing that at the heart of health is love.
Making a diagnosis can be difficult. Making the correct diagnosis is essential. Today, we have visiting us Dr. Brent Barrow. Dr. Brent Barrow is an expert at making a diagnosis. He's a radiology with Vista Radiology. I've worked with him for years. And Brent, we want to welcome you to At the Heart of Health.
Thank you, Jim.
And before we even start all this, I want to tell you that at the heart of health is love. And what we want to do is we want to promote love, because we know that love is a healing force in this universe. And I know sometimes doctors ask you to make a diagnosis, but before we even start, tell us about Dr. Brent Barrow. What got you interested in medicine? What brings you to this point in your life?
Well, you know, growing up, always knew I was going to be a physician, just kind of knew that. Took a little side trip, and as a nurse prior to getting into medicine, actually was a great opportunity and to give you a little different perspective on that. In the practice of nursing, that got me in touch with several other aspects of radiology, but it was really during medical school when I got exposed to radiology and then some of the procedures and the interventional part of radiology that really got my interest, and that's kind of where it led me to today.
Now, radiology is a subspecialty in its own.
Absolutely.
Explain to our viewers what specialists and radiologists, what do they do?
Sure. We're in the process of, we do the diagnosing through imaging of chest x-rays, x-rays of your hands and wrists, that's just regular x-ray, but also CT scans or CAT scans, some people may have heard it in relation to that. Ultrasound, using that for either treatment or diagnosis, MRI, mammography, you know, bone density, nuclear medicine, all different facets of imaging the body to try to gain information to be able to help then clinicians to treat that patient most appropriately for what we find to be wrong with the patient.
So when it comes to making a diagnosis, you're a very much needed part of the healthcare team.
We consider ourselves part of the team.
And you get to probably work with some of the greatest technology out there.
Oh, phenomenal technology.
Now, during your career, has technology changed much, or is it staying stagnant?
Oh, it's amazing. When I started radiology back in...
Well, you don't have to give a year if you don't want to. You don't have to date yourself.
Back, you know, back in the late 80s when I started looking at it, and then 90 when I started training, you know, CT scanning, we call it CAT scan or computer tomography, was in its infancy. I mean, it was a single slice scanner, very slow, 2-second scan times. And now we have 64, 128 channel systems that are imaging, you know, head to toe in a matter of just a few seconds.
Wow.
And part of that has been, you know, the computer development over time has been able to handle the data, but also it's been the technology being able to develop the machines. MRI, a very similar way. Ultrasound's been around for a while. Of course, x-rays. You know, everybody's heard of the upper GI or the barium minima and the plain x-rays, chest x-rays and things. Those have been around a long, long time. And 30 or 40 years ago, that's largely what they had.
Right.
You're looking at shadows, looking at whatever, trying to find out what was going on. Now we're really, really much more specific. We can see down to the, you know, 1/10 of a millimeter sometimes.
Wow. You know, you've seen these television shows where they just move a scanner over your body. It sort of looks like we're getting that way.
We'll be there.
You know, I've really been impressed with how radiologists move information around. I mean, you can move it from one computer screen to another. You don't even have to be there to be able to make the diagnosis sometimes.
No, that's been, you know, the advantage of, you know, high speed, you know, access to things, and the computing power has now allowed us to can image patients in the hospital in an emergency setting. You know, I can be at home The way my group is actually structured is we cover both during the day, we cover all our own after hours. We have members of my group that are either in Jackson, Tennessee, even in Hawaii, that are covering my hospital after hours, because we can move the technology between partners in the practice just, amazingly quickly.
Incredible. Well, we at HeartWise Ministry, we collect questions from people all over the United States and world.
Good.
And what we do, they want answers to specific questions. We try to educate them, and also ultimately want to move to the heart of health. We want to let them know, expose them to love, but we have questions from everywhere. Let's start with a young person.
Okay.
And this person is 25 years old, and she says her mother had breast cancer at the age of 38. So this is a young person, mother has her grandmother had breast cancer and actually succumbed from breast cancer. Her question is what are things should she be doing now to lower her risk of breast cancer? And can you describe the whole process from making the diagnosis to imaging to everything about, she wants to know everything she can about breast cancer. This is real relevant for her because her greatest asset is her health.
Absolutely.
And this is a great question. We hope we can help you. So let's start with the symptoms.
Okay. In specific to her case, because she has primary relatives that have had breast cancer, she is at a higher risk than the average woman of developing breast cancer.
Correct.
If she has sisters, they should be surveillanced. Typically, what the standard is if her mother's breast cancer was at 38, that's on the young end of the spectrum. If her grandmother also had a young age diagnosis, her doctors would probably want to become much more aggressive in surveillancing her. If her grandmother had, a breast cancer diagnosis in her 60s or 70s, she's not quite as risk, but there's a number of things. One of the things in her case, she may actually even have to be carrying a gene that would be potentiate the likelihood of breast cancer. Some things that we can control. We can control our weight. We can control our exercise. We can limit alcohol consumption. Those are all things that we can control that will have a positive impact on reducing her risk of breast cancer. Some things we can't control. The age of when they start having menstrual periods. You can control when you have a child. Women who have children later in life have a higher risk than women who have normally in the 20s and early 30s. So there's a whole host of things, but she probably needs to one, speak to a potentially an expert, maybe even go to a cancer center or someplace where they have counselors who can give her a tremendous amount of information. She may need to get tested for the gene, and that again depends upon her mother's type of cancer, or her grandmother's type of cancer. If she has sisters, they need to be surveillanced and be looked at aggressively as well.
Well, let's assume for discussion's sake that genetic doesn't carry the gene.
Good.
What type of surveillance should we do? What type of imaging would you recommend?
Sure. Screening has 3 parts to it. The first part is up to her, which is self-breast exam. And she needs to learn how to do a good self-breast exam. You do it the same time every month. And usually your practitioner can do that. Sometimes there's a health fair and they can teach you to do that. The internet's an amazing place now, and it can help teach you how to do that. 2 would be to have regular breast exam by your healthcare professional. In her case, it may be a primary care doctor, it may be her OBGYN, but she needs to have a routine breast exam done by a healthcare professional. Thirdly, she's young. At 28, we wouldn't probably recommend mammography, but probably by the time she's 35, we may start, since her mother's diagnosis was at 38, we may start at 35. Mammography is kind of our first line of imaging the breast to try to find any evidence that there's something going on.
So let's say the mammogram. Now, if no one had a risk factor like she does, when would you start getting mammograms?
Routinely for women at age 40.
Age 40.
And then every year or 2, depending again on findings that we have, and but usually we recommend every year after age 40. And of course, there's 2 kinds of mammograms. There's the standard mammogram we've had for years, which is called film screen, and now what you'll hear a lot in the media and people advertise is digital mammography or digital mammogram.
Yeah, I've heard of that. Which is comfortable?
They're both going to be the same.
Okay.
It's I think there is a perception with patients that the digital is a little more comfortable. And it may be that the machines, as they continually develop things, they're trying, patient comfort is of course incredibly important, and they're trying to maximize that. A mammogram does use compression. A digital mammogram still does 2 views of each breast. The difference is the amount of information that is contained in those images can now be looked at on monitors and manipulated and magnified and change the way we look at the algorithms we're using to look at it to maximize calcifications or different things. So the digital mammogram is something that is statistically in most patients has not been shown to be a greater benefit, but at least most practitioners think that it's really a big step in the right direction. So
the digital mammogram, let's say it shows something that's suspicious. What would be the next step?
Okay. She'll get a report. In the United States, we have a number of agencies that oversee mammography programs, the American College of Radiology as well as the FDA. We're required not only to generate a report that goes back to her doctor, we're also required to send her a letter. And if she hasn't heard from her doctor, she'll get a letter from where she had her mammogram that says, please follow up with your physician. You may need a follow-up exam. She or her doctor may call her and say, we need to have you come back. They saw something. Get either what they call spot compression imaging, maybe magnification imaging, maybe a follow-up ultrasound to try to characterize something. So
first she's notified of what she might need to do.
What she may need to do.
We're going to, right after break, we're going to continue this because I think this is a subject that's very interesting to the women that's listening to us. We'll be right back on At the Heart of Health after this brief message.